Good afternoon, all, and welcome to the COVID-19 and Health Inequities Seminar Series presented to you by the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health. This is the third talk of a five-part series running through October 22nd. I'm your moderator, Tori Cowger, and today we are excited to welcome Dr. Kirsten Bivens-Domingo from the University of California, San Francisco. Let's get started by covering a few logistics. The seminar is being recorded, so please turn off your camera if you do not wish to be recorded. The recording will be available on our website at a later point in time. At approximately 2:45, we'll stop for questions, and throughout the talk, you can send your questions via the chat function to Emma Accorsi. We are very excited today to have Dr. Bivens-Domingo presenting. Dr. Bivens-Domingo is Professor and Chair of the Department of Epidemiology and Biostatistics at UCSF and Vice Dean for Population Health and Health Equity in the UCSF School of Medicine. She co-founded the UCSF Center for Vulnerable Populations, a center that generates actionable research to increase health equity in the San Francisco Bay Area, California, and nationally, and she leads the UCSF COVID-19 Community Public Health Initiative. Let's get started. Dr. Bivens-Domingo, thank you for joining us.
Thank you very much for having me. I appreciate being invited to present as a part of this series, and I'm going to focus my talk today to tell you about California. So just to give you a sense of where we're going, I'm going to describe California's experience with the pandemic with the frame of health equity and tell you this story chronologically. And I'm going to end with the introduction this week of a new health equity metric that the state has announced to tie to reopening. So I'd really love to engage in a conversation about this because we think it's the first time to have a metric like this really tied to the types of reopening that are happening, and hopefully to draw more attention and resources to the issues of health equity in this pandemic. So just to orient you to California, for those of you who might not be as familiar with our state, so we're a state of nearly 40 million people. We're a state, the majority is Latino and then white, followed by Asian, with a much smaller Black population that is present in many of the places on the East and the South, and then Pacific Islanders and Native Americans. 27% of Californians are foreign-born. I want to start out with how California experienced the pandemic at the beginning. So on March 4th, we had our first confirmed COVID-19 death. And very soon after that, the 6 counties of the San Francisco Bay Area ordered a shelter in place. It's people who have written about this and people who are in the departments of public health note that there was a strong history of collaboration across these counties, as well as a deep-rooted experience in HIV that led these counties to both have a history of collaborating, of trying to think ahead of infectious disease epidemic, and so they were actually ahead of the state, which 3 days later ordered a statewide shelter in place. So for a large state, I think we took a position very early on that we were taking this pandemic seriously, that we were ordering public health measures, and we were in a period of shelter in place through May 16 when the state started selective reopening. And so what you can see here on the left is that flattened curve, which presumably was as a result of these early measures. What was clear to us who were practicing clinically was that we did not have the experience at all of our hospitals being overrun with COVID-19 cases. We were on high alert, but weren't seeing the cases we expected to see, with the exception that we started to see a lot of Latinx patients. And I'm talking now of my experience. I practice at the public hospital in San Francisco. San Francisco is about 15% Latinx, but nearly all of the patients we were seeing in our public hospital who were being hospitalized and who were having severe cases of COVID-19 were Latino. And so early on, several of us started to talk about that while the city as a whole was doing very well, it was very clear that some portions of our city, in particular our Latino community, was not. So this has led us at our institution to think about where is it that we need to be working in the ways that we generally work to generate data, to engage with communities, to help to drive policies related to our public health response in light of what was clearly emerging as a differential effect in our city, in our region, and across the state. This is an effort, Unidos en Salud, that was spearheaded and has been spearheaded by Dr. Diane Havler, who's the chief of infectious diseases in our public hospital, to basically early on, while we were still sheltered, before it was clear we should be doing mass testing of asymptomatic people, really led an effort to engage with community members in the Mission District, which is a traditionally Latino area of the city, to do mass testing in one census tract within the mission, and recruited many medical volunteers, partnered with the Latino Task Force, which is a coalition of businesses and other community leaders, to start 4 days of testing. This was at the end of April, 6 weeks into shelter in place. They targeted one particular census tract, which based on 2-year-old data is about 60% Latino. And we're really trying to understand both a prevalence of PCR positivity, understand antibody immunity, as well as understand rates and other experiences of those people who might be positive. The model that she and her team developed, which has become our model throughout many of these testing projects that we've initiated throughout the Bay Area, is to do test and respond. So we are testing and have a strategy of testing, but also have a strategy of partnering with the community-based organizations to actually do the types of response that are needed in where we are delivering these types of testing initiatives, which are lower income, and we knew early on we're likely to need more resources in order to respond in terms of the isolation and quarantining that might be necessary. And so this is not something we are doing at UCSF, but rather we are investing with our community partners and community-based organizations who are doing the response part, including hot meals, supplies, and other types of things, and giving people, connecting people into care. So what we found was that there was a high degree of demand for testing over the 4 days. Over 4,000 people were tested. At this time, this represented 30%, nearly 30% of all the testing that had happened in the city. This sample was about 40% Latino, 40% white, roughly dovetailing the demographics of the census tract. The census tract is historically a little bit higher Latino, but this gives you a sense of the distribution of people who turned out for testing. And what we found at that time, that the overall positivity rate here was 2%. This is about 10% higher than the rest of the city at this point in time. Much higher positivity amongst those who are working, who are doing in-person work. And then importantly, the positives are almost entirely among the Latino residents within this census tract, even though the sample is only 44% Latino. What was true of the people who were positive in this sample is that they was characterized by people who were continuing to work but unable to work from home. And so while most people were sheltered, and in fact, this is an area that has rapidly gentrified, so many people were working, but working from home in tech sectors, other types of sectors, but the positives were in people who were out working. 53% of all the PCR positives were people who reported no symptoms, and this was important at the time because we were not in our city testing people who were not symptomatic. And then all of our testing projects have been done in partnership with our Chan Zuckerberg BioHub that does genotyping, which has really been really informative, I think, to tell us about patterns of transmission. So here, if you look by race and ethnicity, those people who were PCR negative but antibody positive, you can see a broader distribution by race and ethnicity. but those who were more recently infected were almost entirely, were entirely non-white, but almost entirely Latino. This is the same that's true sort of really with the genotyping helping us to understand how this pandemic shifted to those people who had frontline jobs as the people who were most recently affected. And again, the genotyping of the virus really helped us to show multiple strains of virus circulating in San Francisco at the time, evidence of household transmission, and really pointing early on to the fact that within this census tract, our Latino residents were really living in multi-family households and some in very densely packed living environments. So the summary of this mission study, which was published in CID, was 2% of persons tested that live or work in the census tract in the mission were PCR positive 6 weeks into shelter in place, about 10 times the rate in the overall city at that time. There were multiple strains that were distributed unequally in the community, and over half of the active infections were asymptomatic. Low-wage Latinx community members unable to shelter in place, living in high-density housing were most highly affected. One of the things I want to highlight before I go on to how we've experienced the rest of this pandemic is how important the community partnerships have been through this, to these types of testing efforts, and how we think they're a very good model of really empowering community with data and actually using this type of partnership to bring about several types of policy changes that have been really important to our city. So this is just describing the impact of the findings. So we showed in the course of this testing the need for more low barrier testing in San Francisco. And this work led to many more testing sites within the Mission District. That symptomatic testing was unlikely to be sufficient to detect infection, and it led the city to change its testing criteria so that all of its testing sites actually took out the requirements for symptomatic testing as a part of the criteria. Loss of wages, we realized in the questioning, was a major barrier to testing, and this led to the right to recover legislation, which basically for low income individuals who test positive, it protects, it gives them supplemental income during the time when they might not be working. And so San Francisco was, I think, very early on in passing this, which has since been passed in several of the other counties in the Bay Area. Job loss is a major barrier to testing, and there have been several other types of pieces of legislation that have been proposed to address this. And I think this has really been a model, and we have worked with many other communities locally, nationally, and internationally to understand this approach, test and respond, and then using data to help to guide our public health response. So this gives you a little more full sense of how California has experienced the pandemic. While we were really terrific on the early, acting early in terms of our shutdowns, I would say that our period of reopening was less than perfect. And our chair of medicine, Bob Wachter, has written about this in a nice Atlantic article. And I think what dominated California's response very early was acting early, acting decisively, acting with a single set of interventions. What characterized reopening was lots of variation across the counties, several counties really having big anti-masking efforts and a lot of fights about masking, which finally led to more statewide mandates on masking. But I think that variability meant that early in reopening around during the early summer months was a very challenging time that then, like throughout the country, led to the second surge for California. But since then has been much more about trying to understand how the state can, as we continue to open despite missteps, do this in a way that we can safely address the risk of surges that happen with the reopening. What has been true throughout, though, is the really widening gap in the disparate income in our racial and ethnic minority, poor, and immigrant communities. So I'm just going to take you on a walk up California, and I'm here set in August. So this is historical data. This is from our health atlas where we're mapping some of these things, but this is not contemporary data. This is the experience in August. So our hardest hit county in terms of deaths is Imperial County. Many people have focused on LA because LA is very densely packed, highly populated, but Imperial County is our county that's been most impacted because it sits on the border with Mexico. It is a very low income county. And I think what we hadn't anticipated in terms of a public health response is how many people actually are US citizens but live in Mexico. And so in planning for the public health response in this county, did not anticipate the back and forth across with Mexico and really the high rates and the massive outbreaks that were happening in Mexico at this time. And so this has really been quite a devastating impact on this particular county, which really wasn't prepared for the massive surge that it had and people who landed in ICUs. This is the county with one of the highest rates of asthma. It's a nearly 80% Latino county and a relatively small county that really was hit quite hard and has had the highest per capita COVID death rates. Next up, I'll focus on Riverside and San Bernardino counties. These are just north as you go here. One of the things that has been striking here, these are counties that have also been highly affected. These are more suburban counties, but one thing that has been featured prominently as people have told the story of these counties is how much these counties are dominated by these big warehouses. This is Amazon's fulfillment centers, and you can see the New York Times did a nice story on the city of Fontana. These are pictures of the same area over each year, over an 8-year period, showing how many parts of these counties are really dominated by these big employers like Amazon that experienced a surge in us ordering online and in these fulfillment centers. But the workers in these fulfillment centers have been are more likely to be recent immigrants, more likely to be immigrants, minority, in many parts of these areas lower income, and they've had issues with both worker protections during this time period. And I think that is an important story that the New York Times has written about. As you go further north, you see the Central Valley, the San Joaquin Valley. This is an area that is our farm belt, and one of the features over the summer is really that the highest rates of cases moved from the urban centers on the coast really to these inland, more suburban and rural areas, and in the farm workers. Farm workers are oftentimes living in very dense housing. This is provided usually by these middlemen organizations, and so these are people who are employed without sort of workplace protections, oftentimes living in densely packed areas, and had really massive outbreaks. There are also several meatpacking plants, food processing plants that sit in this Central Valley area as well that really dominated outbreaks during this time. And then we had a very, how to describe the real devastating impact of our prison system outbreaks that happened during this time. Really dominated by a set of prison transfers that happened as there were outbreaks in the southern part of the state that eventually led to prisoners being transferred up to San Quentin Prison, which sits here in the Bay Area. San Quentin is a large maximum security prison that had no cases prior, but because of transfers and inadequate testing, led to, at that time, the worst outbreak nationally, over 2,500 cases, including 28 deaths of inmates, 27 inmates and 1 guard. The antibody rate, positivity rate in San Quentin Prison is over 60%. This was a massive outbreak. There were a series of transfers that happened even after the San Quentin outbreak that led to seeding an outbreak in some of our more northern counties that themselves had not had cases, community cases of COVID-19. And the important thing in these northern counties, the prison system is oftentimes the biggest employer in these counties. So these are both devastating, obviously, to those who are incarcerated, but also to the communities where prison is a major source of employment. I'll go back now to the Bay Area, and I would say the Bay Area has had a very, very cautious public health response, has had very low rates of infection, although they have surged over this time. But this map from August highlights what is exactly the worsening of the trends we had seen early on in the pandemic, that what the average rate that is very low in San Francisco hides what is true, that the cases are really concentrated here in the southeast sector of the city, and that the west and northern parts of the city really have strikingly low rates. And I think it led me and others to think about how this very different experience leads us to think very differently about what the appropriate types of policy and public health interventions are, that the averages here are really hiding what are two quite disparate sets of experiences across many of our cities. Around this time in San Francisco, we launched some more studies. Again, this is Dr. Havler's team. She was very interested in, again, pushing the city to introduce more low barrier testing. There were several sites across the city, but these were sites that you needed to have a Gmail address or drive-through. And she and her team launched low barrier testing at the BART station. So this is a transportation hub, the subway system. Again, using her test to care model, partnering with community organizations. Over about a 6-day period, they tested 2,600 people. They found it was very feasible to do testing right there at the BART station. They had collaborations with the BART and our Muni subway system. And again showed here now in August, now a 9% positivity rate at a time when the rest of the city was experiencing a 1% positivity rate. And of course, you might be saying we're telling the exact same story over and over again, but now we're in the context of a city trying to reopen. And this is in a BART station, which is a major transportation hub. And these positivity rates, while they really focused on the businesses who are adjacent to this transportation hub and wanting to test people who are employed in those businesses, they were also trying to focus on the ridership. And among people who are about to get onto the subway, the positivity rate was 7%. So really an unacceptably high rate of active infection for a major source of transportation in our region. So we wrote about this in the LA Times on how the pandemic has divided California in two, that really low rates in many parts of the states, in many counties within the counties, but much, much higher rates, often 10 times as high in communities that really are dominated by low-wage workers, and the importance of this cycle being one of the things that has continued to fuel the pandemic in California. So if you look at who our low-wage workers are, that our low-wage earners are in those sectors that we consider essential workers, right? These are the grocery stores, the retail, our agricultural sectors, our restaurants and other food sectors, those people who are caring for our family members in childcare. These are dominated by low-wage workers. And this is from Berkeley's Labor Center. One dynamic that has happened, certainly in the Bay Area, is that we also have another crisis of affordable housing. And what you can see here in the darker parts are across San Francisco, as well as the counties to the south, how on the eastern side of the map here, how you have many more densely packed living environments, which is where our low-wage workers are living. And so workplace exposure oftentimes leads then to transmission to households because of residential overcrowding. And this is worse in California because of our shortage of affordable housing. If you look at the additional contributors that through our testing sites, you can see that economic insecurity, the need to continue to work, is one thing that continues to drive people out of their homes, the inability to isolate once infected, the inability to quarantine household members, the lack of enforcement of workplace health orders within our working environments. And we've had many cases of really bad actors finally getting shut down because of this. But I think there's been an under-enforcement, a massive under-enforcement of health orders in workplace settings, particularly the workplace settings where these low-wage workers are oftentimes working. Lack of enforcement of other workplace protections. There is a lot of confusion now even about once people leave work because of a positive test, of being able to come back to work with workplaces requiring multiple negative tests. So really bizarrely putting a burden on both the testing system as well as our lower income communities sort of caught in this cycle. Immigration is certainly a factor, and the legal status, both people who might not be documented, but also people who are worried about public charge and accessing services like testing being somehow leading to them having lost their immigration status. And then other issues related to language and geographical isolation. We recently tested in Oakland, in the Fruitvale area, in a Latino community, and showed very strikingly high rates among the Maya Mom population there, which is an indigenous population from El Salvador, but who oftentimes are living with obviously the Latino communities, but are not Spanish speakers. And so the additional isolation of those who are non-English speakers as well. This has led to what's pretty clear in California now, that Latino and Black populations, they're overrepresented amongst our low-wage workforce, and then they're also represented in higher numbers among our cases and deaths. You see Latinos represent 60% of the cases in California, 40% of, as I mentioned at the outset, they're also overrepresented in the younger age when you look at deaths happening in between ages of 18 and 34, both Latino and Blacks. So here's the problem. We're trying to, we in California have been achieving improved case rates in many of our counties, but we have not yet achieved very low transmission rates. Many counties have neighborhoods with substantially higher rates of transmission. And in these neighborhoods are most likely to be those neighborhoods without the resources to address, which we've already talked about. So from our perspective, the focus on equity is about relieving suffering in these communities, but it is also about the best pragmatic pandemic management at this point. And that's been very clear as we've thought about this, certainly in San Francisco, but with our colleagues at the state as well. So faced with this, California recently launched a new health equity metric that's really focused on the disparities of COVID-19 impact. We believe this is a first in the nation approach that is really designed to focus our attention on the disproportionate impact that the coronavirus is having in disadvantaged communities. This was literally launched this week, so I'm not telling you whether we've been successful at doing this yet, but I want to discuss, because it is a question I think that many of us who are interested in equity think about how we should be operationalizing it, which I think is one of the things that the state took on, and I think may be a model that we think in many of the other arenas that we want to focus on equity. Was a focus in the report that came out from the National Academies related to the equitable distribution of coronavirus vaccination. and certainly is of interest, I think, in trying to alleviate this disproportionate burden in many of our communities. So here's how the metric works. It's utilizing the California Healthy Places Index. The Healthy Places Index characterizes census tracts based on these factors here: economic, education, transportation, social, neighborhood, and clean environment, housing, healthcare access. These various variables are regressed on life expectancy. So it's different than some other measures like the Social Vulnerability Index or the Area Deprivation Index. This is actually regressed on an outcome. We can talk about whether that's a good or a bad thing, but that is what happens with this Healthy Places Index, and it has been designed for California. The idea is to designate census tracts into quartiles based on most disadvantaged to least disadvantaged, and the health equity metric basically is designed to say, is the positivity rate in those lowest quartile counties, we want to make sure that their positivity rate does not lag behind the average for the entire county, right? So this is how it looks in San Francisco. So what you see here in blue are the census tracts that are in the lowest quartile. And here in this graph, this is from a few weeks ago, it's graphing test positivity and percent Latino. And what you're seeing here in the blue is those counties that are in the lowest quartile based on the HPI. This is not a metric that is telling us about necessarily about the areas of town that have highest Latino residents. It is also not saying we're trying to identify counties with the highest positivity rate. It's really focused on saying the parts of the county, the census tract that have the least resources to address a high positivity rate. If the positivity rate is high in those areas of the county, then the county needs to refocus its effort and attention to those parts of the county. There have been other people who've asked that a metric like this be focused on race and ethnicity. There are many reasons why it hasn't been, but I think there is an advantage by really focusing on measures of disadvantage within these census tracts, and then asking when the positivity rate in these disadvantaged communities is high, then the county cannot move to reopen and must address the needs in those communities. So this is sort of our blueprint for reopening. A county has to show what its numbers of cases have been over. This is a daily case count over the last 7 days, lagged by 7 days. It's a little bit more complicated. That's why it's adjusted here. And it has to show that it has a positivity rate here before it can move to the next level of reopening. And you can see the type of reopening we're talking about here in the county risk level. This is from 2 days ago. 4 of our counties fell short of the state's new equity metric. This is the first week of the metric that would have allowed us to advance to reopening. And one of the counties is San Francisco. So if you look across the Bay Area here, San Francisco is in the best position to consider reopening. We have a pretty low, our positivity rate is about 1.4%. Our new cases about 2 to 3 per day, but because we are not meeting the equity metric, we are not going to move to the next phase of reopening. You can see that some other counties within the region have actually met the metric, but have too high transmission to move to the next measure. So that is the rationale behind doing this. When a state fails its metric test, it's required to deliver a plan to the state about how it will invest and address the needs in its community. Presumably some of this needs is just shifting testing. Oftentimes that's one thing we've noticed is just shifting testing to these areas has been an important feature. It does mean, of course, you find more cases, but because these are areas that are often under tested, testing is part of the strategy. For San Francisco, it's also meant investing not just in in testing, but also aid to communities. And so this was an announcement that the mayor made before the actual introduction of this metric. So I can't say the metric prompted this, but I think there was word from the state that the governor was interested in introducing this. And there had been a lot of both pressure as well as a lot of dialogue with the city government about the really substantial impact of COVID-19, plus the economic recession on our Latino communities. So here's the reflection. So if I think about California as a whole, we had an early and effective response to the pandemic. This response became more variable over time. Even when we were doing things well, we had disparities, and these have widened during reopening. We are in a better position now and have had overall improvements, but we've had very high rates of transmission, particularly related to in-person work among our low-income communities. The rates are highest in Latinos, immigrants, but also in Black, and I haven't talked as much, but in Pacific Islanders as well. There is a new health equity metric that is designed to force attention and resources to address this issue as we continue to reopen. Will the metric work? I think it's too early to tell. Some critiques of this metric have included limited attention to race and ethnicity, as well as occupation. And the need to focus attention on the disparate impact of the pandemic is critical. And I think the equity metric is one step in this direction. In my view, this is our moral, ethical, and social responsibility, but it is also just pragmatic and good public health. This quote that I am very fond of is "Averages are no consolation to those who've been left behind," is from Sir Angus Deaton. And I think speaks to much of what we've observed throughout the pandemic. And I'm really happy to have questions and engage in discussion on this topic.
Thank you so much for that talk, Dr. Ribbins-Domingo. For the next 15 minutes, we'll take some questions from the audience. We'll try our best to accommodate as many questions as we can. If your question does not get covered, please feel free to reach out to Dr. Ribbins-Domingo directly. Remember to submit your questions to Emma via the chat function. So the first question is, how do the intersections of racialized legal status, language, and socioeconomic position interact to create unique vulnerability to COVID-19? And how do you balance the need of better data to shine light on inequities with very real risk of disclosure and harms to individuals and communities?
Yes, I think you are speaking to, yes. So I think the intersection of these really is clear. If you can think in very linear ways about the intersection of the factors that you are talking about, and I think we've seen that play out across the country. I think in a very diverse community like the Bay Area, I think these play out in complicated, sometimes unexpected ways, and in ways that one of our goal in doing this work collectively with my colleagues is and community organizations is also not to have the multiple groups, multiple communities that are disproportionately affected view this as a zero-sum game, and that there are ways in which marginalizations related to racism, related to language, related to poverty come together in unique ways across communities, but have led all to a disproportionate impact. One of the things that I'll say is that it's clear that African Americans make up only 5% of the population, 6% of the population in California, but it is clear that they have by far the highest per capita death rate. It is something, but if you look at just cases, the cases are overwhelmingly in Latinos, right? The ways we get there are exactly the same, the marginalization, the historical marginalization and the ongoing oppression is the same, but it plays itself out in very different ways. And part of our goal is not to have the stories and factors in one community overshadow or outstrip those that are happening in other communities. That's been one of our challenges. The issues of stigma, I think, are also important. And one of the things early on we wanted to do as we were highlighting this work is not to have people afraid to go into certain neighborhoods in the city, people not be worried about hiring our Latinx workers. And I think that we've achieved mostly by partnering with the community organizations, actually, because they are the deliverer of the message. They've helped us craft the message to lawmakers. They have to craft the message back to the community. That has actually helped to large part. I'm really curious what people think about what will happen as we adopt this health equity metric, though. One of the reasons that the National Academies adopted a place-based metric of equity as opposed to thinking about race and ethnicity in their equity metric is because I think they were worried about stigma. And I think it's an interesting take on this. And in my view, I think the place-based metrics have some value, but there's also, there's a need to call out the additional issues related to factors that are not place-based, but are related to race and ethnicity that place-based measures may not fully capture.
Thanks. The next question is about a little bit of what you touched on in your answer here, but what advice do you have for working with community partners? What makes for a successful collaboration with those partners?
Yeah, yeah. So I think in this case, the things that have worked to our advantage is that the communities have mobilized and in a structure that is much easier for a university to interact with and engage with. It's usually a structure that's made up of leaders of multiple community organizations and civic leaders. And so when we partner with them in all of the cases where we've done these testing events, I think it's been because we've had a very strong multi-sector but unified organization, the Latino Task Force, the Unity Council, that really is our lead partner. I will say the first set of these testing efforts often comes with what I call a little bit of truth and reconciliation types of meetings. We as academic institutions sit with a legacy of our own oppression with the communities. There's our own multiple years, often decades of mistrust of actions that our institution has taken in the community, whether we know them or we don't know them. And so I think the partnerships come with being willing to hear and listen to what has to happen to do this well. I think there's a real opportunity in this time of COVID because of the urgency to address some of these needs to do this. And I think it's the urgency both on everyone's part that has allowed us to listen very actively, to think about what has happened in the past that has not gone well, and try to make those adjustments to do them well as we've gone forward in testing. We have a strong commitment to giving results first back to the community. We have a strong commitment to having our community partners craft our message before the message goes out. We just tested recently in Oakland in several different communities, and we've adhered to that. We have a strong commitment to redoing how we're doing testing based on what the community wants. We have gone from some very large scale testing events in our Latino neighborhoods to very small pop-ups in our to target more outreach to African Americans. And I think that has worked successfully. I think that because we are giving data back to communities and helping them use the data to advocate, I think that has actually built up a lot more trust. And so each subsequent testing event is actually, has actually been easier to do because we've built up trust and currency over time. But the first ones took a lot to get there, frankly. And I think my hope is that while testing is our main motivation now, my hope is that the trust that we've built up in doing this is what we will leverage as we get to the point of vaccinations, because it is that same trust that you really can't build up overnight. And we have, I think, over time been able to do this. The last thing I will say is we're also investing in the services that the community-based organizations provide. So we're actually putting our resources back into the community. They are providing the services. And so I think in that way, it really is about building these community organizations up during a time when they are also feeling the economic devastation. And I'll say, you know, we do pay for our volunteers. This is a time of an economic recession. We pay our volunteers to do the canvassing. We pay our volunteers to get the word out. We do a lot of that because it's essential during this time.
Thank you. The next question comes from the director of CCDD, Dr. Mark Lipsitch, who says, "Thank you for your great talk and especially showing how good social epidemiology can change policy." He has two questions, so I'll give them to you one at a time. So the first question is, you listed a tremendous number of proximate mechanisms by which disadvantage leads to higher risk, and these lead to different interventions. For example, household crowding versus workplace, unprotected workplace exposures. How do you think about trying to disentangle these to inform interventions?
Right. Right. So I think from an epidemiological point of view, we in our testing studies have been building out some more case control studies to really understand both workplace exposure and the exposure for household members. From a policy standpoint, I think we are underutilizing the only policy lever we have in this regard, which is enforcing better workplace protections. And I think that I'm also trying to be pragmatic at this time. I think we have to figure out how to enforce the workplace protections better. The back end of the overcrowding would be easier if we were able to prevent the initial case coming into the household. This is also a little more up in the air as we think in ours about school opening, and I think the issue of overcrowding, where San Francisco is a city with one of the lowest child populations of any urban center. Where children are in San Francisco is in our Latino communities. And so the issues of this has now come up to with the dense housing environments in thinking about children in schools and other things. But I think we have underinvested in the policy levers to really both educate and actually enforce in the workplace.
Great. And the second question is, I wonder what choices you thought about in designing the equity metric. It seems well designed to incentivize testing, which is good, but it seems that one can meet the metric by testing well without getting good control across the population.
Yeah, super. So actually, the metric doesn't specify what your intervention has to be. So you have to deliver the county has to deliver a plan back, and it's suggested that the plan would include testing. It might include, we have the ability in San Francisco, for example, to use hotels for allowing people to isolate and quarantine who have difficulty doing that within their housing environment, so that it can include any number of those things. But I think what we realized in several parts of the Bay Area is that it was also clear we were under testing relative to where cases are. And so that is why an emphasis is on testing. What we didn't want is for there to be more testing in the state. The state had to ramp up testing, and they ramped up testing. And obviously, if you test only on the western side of San Francisco, you can completely lower your positivity rate very effectively, reach your testing metric, which is how the metric was designed before, and never get transmission under control. And so I think that is why for many counties, the focus is on testing, because because the feeling is that the positivity rate for the county is not representing true positivity rate within the county.
Great. Another question on testing asks about testing for workers. So at one point in the talk, you indicated that the requirement of multiple negative COVID tests before a worker could return to work poses a burden on already impacted low-wage workers. Was the suggestion that clearance criteria be less stringent, or was the point that additional resources and support are needed to mitigate additional burden from safety policies?
Yeah, I mean, I think the CDC, you all can tell me if you don't think the CDC is correct. I think the criteria to clear someone is not a test-based requirement. It's just a time-based requirement unless you have severe disease. And so the fact of employers requiring multiple tests is just a misread of both our state, our local public health mandates here. But what's happening is it has made people who need to be newly tested fearful of being tested because they see other people who have tested are clearly over their COVID-19 and cannot return back to work. And so this is not just a temporary, I'm off of work for 10 days, it is I'm out of work for months because I can't get back to employment. And so that is one where we've really tried to push with our local departments of public health to really get the word out better to employers. We've had in our testing sites, trucks roll by with day laborers where people will come out and want to be tested, but they will ask, can this be anonymous? Will you have to tell someone? And you can see that people are actively making decisions between testing and employment. You can see it anytime we go out there to do these testing events.
So I'll ask a follow-up question on what you just said, which is, what do you think is the kind of solution? Is it additional social supports to workers? Is it worker compensation, paid sick leave? Like, what do you see as the follow-up to kind of ameliorating that fear that workers might have?
Yeah, I think so I think the right to recovery funds I think have been helpful in the Bay Area. So that is the right to receive funds if you're out of work because of COVID-19. I frankly also think that there are different elements that might be needed in different communities, and we've learned a lot from our community leaders. In Marin County, a fairly wealthy county north of San Francisco, they have about 70% of their cases are in Latinos. They had developed this isolation and quarantine program for their areas that were more densely populated, but it was in areas nobody could go to. And so they worked with community leaders just to basically make those types of services ones that people would actually utilize. And I think you see a lot of policymakers putting interventions in place, but not ones that community members are actually using. And so therefore they're completely ineffective. I do think they fall in this basket of providing some tangible resources in terms of for lost wages, helping people to isolate and quarantine by putting them into different environments, but those have to be environments that people are willing to do. Paying attention to basic needs. We, in our most recent testing at site, 50% of those tested, we tested about 2,000 people, 50% of those tested who came to the testing site were experiencing food insecurity. Some of this is basic food needs, food for the family. So if someone else is isolating and it's the breadwinner, how does the rest of the family that's now quarantining get food during this time? That's one of the things that we've been very focused on. And I actually think people, while I'm describing this as people's making these trade-offs in their mind about getting testing, mostly what's happening now because we have been under testing is that there's so much fear and misinformation. When we've come in, I don't sense that there is a barrier to doing these things because we've put the supports into place on the back end. And so I don't think these are insurmountable. I think they require developing solutions people will actually use, and community leaders are oftentimes best able to say what those will be.
Great. I think we have time for one more question, which I think will segue well from your last answer, which is, how do you make the case for the importance of health equity in economic and policy responses when those in power are often not the most heavily impacted by the pandemic?
Yeah, it's a really good question, and those of you who are infectious disease epidemiologists can tell me. I look at San Francisco that's trying to reopen, and I oftentimes talk to groups in different settings, businesses who are saying, well, we want to reopen. How can we keep our workplace safe? And I'm trying to imagine a Bay Area that is going to open up, with a 10% positivity rate on people riding BART. There is a way in which, although we live very different lives, there is a way in which our livelihoods are all entwined during this pandemic. And I think there's a lot of interest in trying to understand and quantify that in a way that says, this isn't just because we really need to address the people who, the communities that are suffering, but that as we try to reopen, construction is one of those businesses that have been open, has been open more quickly than others. Restaurants is one of those industries open more quickly than others, that in our city has a strong Latino workforce that needs those sectors in order to be open. BART and the ridership across the Bay Area is necessary for many, many of our businesses to reopen. And I don't think that happens at a time when we have really infection rates that are so disproportionate and includes the communities that really are important to those sectors. I can't quantify it, but I do. That's my inclination, and I think that thought is what underlies this metric and underlies people's thinking right now.
Perfect. Well, thank you so much. And on behalf of the Center for Communicable Disease Dynamics and the Harvard T.H. Chan School of Public Health, I would like to thank you, Dr. Vivens Domingo, for joining us today. And I'd also like to thank all of you for tuning in to the third talk of the COVID-19 and Health Inequities seminar series. We hope to see you at next week's presentation on Thursday, October 15th, featuring Dr. Tanjana Purnell from the Johns Hopkins School of Public Health for her talk titled Race, Racism, and Health Disparities in COVID-19. Thank you all again for joining.
Thank you.